All right. Well, thank you. Good morning, everybody, and bonjour. Thank you for inviting me. Thank you for the organizing committee. So I'm glad to talk to you about fear of cancer recurrence. Title of the talk is Fear of Cancer Recurrence, What to Look For, How to Look For It, and What You Can Do About It. I have no disclosure of conflicts of interest, so we're off to a good start. Learning objectives. So to think about what fear of cancer recurrence is and how it manifests itself depending on its severity. We'll talk about how to distinguish between normal fear of cancer recurrence from more severe fear of cancer recurrence. I want to give you some questions that you can use with your patients to assess their level of concern with fear of cancer recurrence, and sort of have some general knowledge about what psychological interventions to help patients for fear of cancer recurrence are and what's currently recommended based on the scientific literature. All right, so I'd like to acknowledge the numerous collaborators in Ottawa, Montreal, and Toronto, including somebody you probably all well know, Dr. Sarah Ferguson at PMH, who've made this research possible. All right, so the agenda is to tell you about a definition of fear of cancer occurrence and prevalence. I'll briefly talk about the impact of fear of cancer occurrence on psychological adjustment and healthcare use. I'll give you some idea about measures and screening tools that are available, and as well as some potential questions that you can use with your patients to screen for fear of cancer occurrence. I'll give you an overview of existing interventions, and then I'll tell you some tips and things that you could do to address fear of cancer recurrence in your patients. And then we'll have a question period. And I did have the pleasure of creating 2 questions. They're not as fun as the questions we just had, but nonetheless, as a university professor, it's always fun to come up with like exam questions, so hopefully you bear with me for those. All right, so fear of cancer recurrence. In 2015, I had a bunch of experts on fear of cancer recurrence meet in Ottawa, and we came up with a consensus definition of what fear of cancer recurrence is. So we define it as fear, worry, or concern related to the possibility that cancer will come back or progress. You'll notice there are a couple of things that are important about this definition. One is the idea that sometimes fear of cancer recurrence is a realistic concern that patients have. And the other one is that we've made this definition inclusive of people whose cancer will never go into remission. These are people with, let's say, slow-growing tumors. And what we're looking at here is fear that the cancer will progress or worsen. Fear of cancer recurrence is usually the top unmet need, or it comes in the top 3 unmet needs of cancer patients across the disease trajectory, regardless of the type of cancer. So an unmet need is basically a supportive care need that is currently not being addressed by a patient's medical team. So for example, this is work done by Margaret Fitch at Sunnybrook. She did a couple of studies that showed that between half to 3/4 of ovarian cancer patients report fear of cancer recurrence as an unmet need. It's usually something that manifests itself shortly after diagnosis, and recent systematic reviews have found that it's stable over time. That means that shortly after diagnosis, some of your patients that have fear of cancer recurrence or during treatment, chances are these same patients will experience fear of cancer recurrence a year or 2 later unless it's addressed. Prevalence rates of fear of cancer recurrence vary a lot across disease sites by study, so we always find these very wide prevalence rates. So the citation there is for a review of fear of cancer recurrence in ovarian cancer patient, and that systematic review found that between 22 to 80% of ovarian cancer patients report fear of cancer recurrence. So why this wide range? One of the reasons is measurement issues. So it really depends how you ask the question. Some studies simply ask patients, have you ever had a thought about cancer coming back? And that's when you get those 80% or more. Some studies have found 99% of cancer patients will endorse, yes, I've had a thought in the past that cancer could come back. And then it depends. The second issue is not only measurement, but fear of cancer occurrence, and you're probably all aware of this, is an experience that manifests itself on a continuum ranging from kind of normal to clinical or excessive. What I mean in my practice by normal fear of cancer occurrence is people that, upon having their yearly or twice a year visit to the cancer center, and they're waiting for their exam results, are experiencing some anxiety as they're waiting for the results and waiting to meet with their oncology team. But that they'll find that this distress is kind of time limited to those appointment times, and that in general, while they're distressed during that time, they feel they can cope and they can manage, and then after that, in between those times, they're okay. That's what I call a normal response to fear of cancer recurrence. So those are the people that, you will get those high prevalence rates of yes, I'm sometimes preoccupied with fear of cancer recurrence. These are not the people that this talk focuses on. What I'm focusing on is people that report clinical or excessive range of fear of cancer recurrence. And that looks like someone that has, you'll see, most likely weekly, if not daily, preoccupation with fear of cancer recurrence. So several of the people that come to see me say that it's always on the back of my mind. And these people will have a lot of strong emotions associated with their fear of cancer recurrence, fear, sadness, anxiety, anger, that they find difficult to manage, and they find it's having an impact on their life. And when you look at that level of preoccupation with fear of cancer recurrence, you're looking at much lower percentage, with our best estimate being around 10% of patients presenting that level of severity. But overall, our best guess at this point, based on these systematic reviews, is that about 1 out of 2 cancer patients experiences at least moderate to high level of fear of cancer recurrence. So 1 in 2 probably needs further investigation in terms of how much fear of cancer recurrence they're reporting and possible referral for additional services. So what is clinical fear of cancer recurrence? So what should you be looking for in terms of signs and symptoms in your patients? So the top one, so this is the same group of experts that met in 2015. We came up with these 5 criteria. First one would be high levels of preoccupation, worry or rumination or intrusive thoughts about the idea that the cancer could come back. And then you have the presence of some maladaptive coping strategies. So that will change from patient to patient, but commonly you'll have people who tell us, well, I really do the best I can to avoid thinking about this. Or they'll avoid people or places that remind them of cancer, or sometimes they'll avoid coming to their medical appointments. Then you have people who use a lot of reassurance seeking. So that could be reassurance seeking from you. These are the patients that may be asking for an additional test, or despite the fact that they've been told, no, we don't really do this test, they're kind of pushing for it. So it could be people that go see their family physicians also for reassurance and counseling on more than needed. And it could be also that they're turning to their loved ones for that kind of reassurance. So I once had a patient who coped with this by grabbing her husband by the shoulder, and he had to tell her, yes, everything is going to be okay. So you also have people who spend an excessive amount of time online researching treatment options or signs and symptoms of recurrence. So I once helped somebody that was spending on average 3 to 4 hours per day looking at various ways to help himself with his cancer. Then you'll have people who also check for signs and symptoms in their body beyond what's been recommended by their medical team. And then we find that people with clinical fear of cancer recurrence have what we call functional impairment. This is having an impact on their ability to go back to work, on their relationships, on their ability to function in their day-to-day life. And of course, there'll be excessive distress. And the last one is difficulties making plans for the future. So many of the patients I see tell me, I'm feeling stuck. I feel like I've got no purpose or direction. I don't know how to move forward because what if I die next month? So people feel this difficulty making plans even in the short term. All right, so we further delve into what clinical fear of cancer recurrence looks like in a qualitative study of 40 cancer survivors, using a screening instrument that had an established cutoff score to distinguish people with possible clinical fear of cancer recurrence from those that were in that more normal range. And people who were in the clinical range reported cancer-related thoughts or sometimes images that were difficult to control. So they're having a difficult time managing this. These images, as I mentioned, were daily and recurrent, persistent. They lasted 30 minutes or more of their time every day. They tended to increase over time, so they didn't decrease. People actually would tell us, well, as I'm getting older, my chances of getting a different cancer actually increases. Cancer is something that happens to older people, So they actually were more afraid as time went by. These thoughts, of course, cause distress, impact their daily life. And these patients also reporting having a hard time tolerating uncertainty. So that's kind of a hallmark. Intolerance of uncertainty is really the difficulty tolerating even small dosage of uncertainty. And what that can look like is, we talk about it as kind of being allergic to uncertainty. And cancer has so much uncertainty. And people feel like, well, uncertainty equals danger, equals a very poor outcome. So these patients have a hard time tolerating the uncertainty that comes with the cancer experience. They were also, when they thought about their cancer, their mind went to death and dying. And people with lower levels of fear of cancer occurrence, the more normal range, when they thought about their cancer coming back, what they thought about was having to go through treatments again, or what would happen to their loved ones who were going along with this. But people who were preoccupied with cancer, had fear of cancer occurrence in a clinical level, thought about death and dying. And these people report feeling alone in the experience, despite the fact that sometimes they had good supportive families, but they felt like no one could understand them, and they tended to isolate themselves and not talk about it with anyone. And the last thing that really distinguished them is that they were convinced that the cancer was going to return. So they knew that their team had told them that their chance of recurrence was, let's say, 20%, but they told us, I know about the 20%, but I'm convinced 100% that I'm going to be the one that has a recurrence. All right, so this will come as no surprise to you, but of course, fear of cancer recurrence is associated with psychological distress and lower quality of life. This is data from systematic reviews. And also, interestingly, for you guys, fear of cancer recurrence is also associated with an increased use of healthcare services, whether it's more visits to GPs or to the emergency room, or more use of supportive care services. And we actually did a study at the Ottawa hospital looking at a time where we were transitioning out endometrial cancer patients to primary care physicians. And we had done a qualitative study of some patients. And those that had high fear of cancer recurrence were not happy to be transferred back to their family physicians. And they were actually more likely to want to be referred back to the cancer center because they felt more reassured by being in the cancer center. Okay, so despite the fact that there's really been in the past decade a lot of interest in fear of cancer recurrence as a field of study, and despite the fact that this is a really prevalent problem and it has a high psychological morbidity and healthcare costs associated with it, there isn't a ton that's well known about risk factors about who develops a fear of cancer recurrence. Here's what we know based on the scientific literature. People who have physical symptoms, such as aches, pains, fatigue, are more likely to report fear of cancer recurrence. And I thought that was really interesting from the previous talk. So the women who were waiting longer, those that had more physical symptoms said that this was harder as an experience. We think those physical symptoms act as internal triggers. So what that typically looks like for me is that patient that comes and says, I've had this headache for the past 2 days. I'm pretty sure I've got metastases to my brain now. So the more physical symptoms you have, the more likely you are to attribute these physical symptoms to signs of recurrence. As I mentioned, there's also your own perceived risk of recurrence versus your objective risk. So people are aware of their objective risk, but they have their own number in their mind about what's going to happen to them. And the higher that number is, the higher their level of fear of cancer recurrence. And people who use avoidance in general report more fear of cancer recurrence. There's very limited data, or actually there's a lot of data that shows very limited impact of sociodemographic variables. So marital status, education, income have very little to do with fear of cancer recurrence, with the exception of age. So younger patients, there's several studies across the board that show that younger patients report more fear of cancer recurrence. There's a bit of ambivalent data about gender. So there's some studies that show that women report more fear of cancer recurrence than men. However, I think the quality of that data is lacking, so we don't have firm conclusion about that. And then people are usually surprised at this part of my talk when I say that medical factors and treatment variables have very few influences on fear of cancer occurrence. So people expect that cancer patients with higher stage or those that go through more aggressive treatments will report more fear of cancer occurrence. But systematic reviews have found that that's usually not the case. It's really more about how the person perceives their own risk than the objective medical risks. All right, so what should you do given that there's this high prevalence of fear of cancer recurrence? Currently in Canada, we don't have guidelines yet published about how we should manage and assess and treat fear of cancer recurrence. However, guidelines were published in Australia about 6 years ago. So I turned to these guidelines for some suggestions. And these guidelines suggested that based on the prevalence rate of fear of cancer recurrence, every cancer survivor should be systematically asked for their level of fear of cancer occurrence across the disease trajectory. There's also recent evidence of a study in Scotland with head and neck cancer patients that shows that this is especially important because Cancer patients will tend to underreport their fear of cancer recurrence to their team, and the main reason was they feared appearing ungrateful to their oncology team that, well, how could you be preoccupied with cancer coming back? We just went through this together. So I think it would be important to screen for them, and there are well over 30 measures available to do that. And I cited here a systematic review, which I've also given you the reference for, that reviews these measures, short ones, longer ones. The main issue here is that these are research instruments. So no measure is currently being routinely used for screening in clinical settings or as published on that topic anywhere around the world. So that leaves you ill-equipped to pick an instrument and apply it in your center. I would have some recommendations, but know that very few centers are using this for that purpose. Of course, there's the ESAS, which you're all familiar with, and it's got an anxiety item. So sometimes in our studies, we've used the ESAS to try to capture people for our trials on fear of cancer recurrence, to try to capture people who are likely to be experiencing fear of cancer recurrence, but the usefulness of the ESAS anxiety item as a screener for fear of cancer recurrence is unknown and unstudied. So, given this, what can you do to screen for fear of cancer recurrence? I think you'll have to ask some questions to your patients. First one would be just the presence of fear of cancer recurrence, such as asking, are you ever afraid that your cancer will come back? But that alone, as I showed you earlier, is not enough to get at that, because you could have 80%, 90% of your patients saying, yes, sometimes I'm afraid of my cancer coming back. What you want to get at is frequency. So what we're looking for here is people who experience this at least weekly, if not several times a week, or daily. So how frequently do you think about the possibility that your cancer will recur? And severity, to what extent are you scared that your cancer will come back? So here you're looking for strong emotions that people are finding difficult to manage. And of course, there's desire for help. Do you need help to manage your fear of cancer recurrence? And if so, then I would suggest that you consider referring. In terms of evidence for psychological treatment, there's really a growing interest in helping people deal with fear of cancer recurrence. Maybe this will come as a surprise, but the first published randomized control trial on this issue was only done in 2009, 2010. And this was done in Germany in a very different context than ours, as people were seen as inpatients post-treatment and people receiving rehabilitation services. And this team in Germany found that in a mixed cancer sample, group cognitive behavioral therapy and group supportive expressive therapy were helpful in terms of reducing fear of disease progression compared to a control group, a waitlist control group. And then we've got also evidence, growing evidence that mindfulness, for those of you that are familiar with that term, mindfulness stress-based reduction interventions can be beneficial for fear of cancer recurrence. And then we have a couple of really good trials that were published in JCO recently, looking at cognitive behavioral therapy, one-on-one, individual cognitive behavioral therapy. All these therapies are very brief. We're talking about 5, 6, 7 sessions. The last one came out of Holland, and it was a blended model of individual services and online services, and both of which found that, at least in the short term, these therapies seem to be helpful. There's also now protocols of groups looking at just online interventions for fear of cancer recurrence. Just to mention that in Canada, we also have our own trial going on testing an intervention for fear of cancer recurrence. It's funded by the Canadian Cancer Society, and I'm part of that. So what we're looking at is a 6-week group intervention, and it's a mix of cognitive behavioral therapy and existential therapy, and it's done with women with breast cancer and women with any gynecological cancer stages 1 to 3. And the trial is being done in Ottawa, Montreal, and Toronto, and we're pretty much almost done with a couple of groups starting in May, and we'll have results in September probably for that. So, based on what I've just showed you, there's really now a good amount of evidence that your patients would benefit from for referral for cognitive behavioral therapy or mindfulness intervention. So there are systematic reviews that show that, and we're now working on meta-analyses to gather a good strength of evidence, but it looks promising that these therapies are helpful. There's also evidence that you could suggest making positive health changes, and that cancer patients who make more health changes also seem to experience less fear of cancer recurrence, although I'll just mention that these are cross-sectional studies, so no, we're not quite sure how the relationship goes, but Probably doesn't hurt to make positive health changes without going to extremes. I mentioned that because as a clinician, I've come across many patients who feel like they must adhere very closely to very specific diets or very specific exercise regimen, and that seems to become a little too excessive. Now there's the question about reassurance. So I'm sure this comes up in your practices a lot. So how much reassurance should you be offering? I think the scientific evidence would be to be mindful of offering reassurance to patients who are very high on fear of cancer recurrence as something that could backfire. So be mindful that reassurance in the short term can be beneficial for most patients, but in the long term for people with very high fear of cancer recurrence, this could be just something that fuels their need for more and more reassurance. So the relief that patients get from additional tests or from the results tend to be short-lived. So this was a study done in the States with women with breast cancer who had completed treatment and found that the month before mammogram, the anxiety would increase shortly after, or immediately after finding out that their mammogram came back all good. Women reported a decrease in their anxiety, but that anxiety increased within a month. So that reassurance could be short-lived. So I wanted to tell you a bit about our intervention that I mentioned, the 6-week group intervention, to sort of see if there's anything in there that you could be using with your patients that deal with fear of cancer recurrence. So here are the goals of our intervention, and while not all of these 6 goals will apply to you, I've pulled 3 that I think you can use. The first thing we teach our patients is to identify triggers of their fear of cancer recurrence and identify what they're doing in terms of coping that's not helpful. We help them learn and use new coping strategies. We help them distinguish worrisome symptoms from benign ones, and here I think you all have an important role to play. We help them increase their tolerance for uncertainty. We promote the emotional expression of specific fears. So everybody's got some specific fears about what could happen if their cancer were to come back. We just get them to talk about that and expose themselves a bit more to what that means. And finally, we help them re-examine life priorities and set realistic goals for the future. We'll talk about what that looks like. So in terms of things you can do, I think you all have a role to play in terms of educating your patient about what a helpful versus an unhelpful coping strategy looks like, with the goal of decreasing maladaptive coping strategies. So for example, you could explain to your patients what happens to anxiety over time when people over-rely on avoidance, or when you overcheck your body for signs and symptoms of recurrence, or if you're spending an excessive amount of time online, especially looking at things that might not be helpful or anxiety-provoking. Or what happens if you overfocus on your medical sensations, you tend to misinterpret everything as a sign of cancer coming back. You could help patients by discussing sort of the pros and cons of like spending this amount of time online researching this, or spending, asking for these additional tests. What are they going to gain out of this behavior? And then you can review with them appropriate coping strategies. So appropriate coping strategies could look like making these positive health changes, for example. It could also be adopting stress reduction activities like practicing yoga, practicing some mindfulness exercise. It could look like attending a good support group. It could look like turning to your support system. It could look also like getting proper medical information and learning to distinguish between what is a helpful source of information versus what isn't. I think here's one where you could really focus on. A lot of people I work with, I've never asked their team anything about their own particular statistics about fear of cancer recurrence because they've been too scared. Many of our patients feel like they're not quite sure what to look for in terms of signs and symptoms of recurrence. They've never had that conversation. They're unsure about what to do if a recurrence does happen. So there's a lot of uncertainty. So having information reduces uncertainty and helps patients. You can review with your patients what has been consistent and predictable about their disease and what information they feel they have a sufficient amount of. And then review what's been unpredictable about their disease and any kind of knowledge gaps that they might have. And I think it's really important to give them good information about symptoms to watch for, what to do if symptoms are present, and where they should turn to, who should they call, how does that work, how do I get it referred back, what is going to happen to me. Give them the statistics around their cancer if they want to know. And also important, a lot of patients come to our therapies and feel like, well, if the cancer recurs, there's nothing that we can do, right? There won't be any more options for me. And I think sometimes just hearing that, well, there are additional treatments if you do have a recurrence is reassuring for some people. I think it's important to tell patients that even if you give them all the information in the world, there will still remain uncertainty around the cancer coming back. So even if you give them the best and the latest up-to-date information, there's still a lot of gray zones with cancer that people have to deal with. So you can help them increase their tolerance for uncertainty. We all deal with a lot of uncertain situations on a daily basis. Most of your patients have probably coped with difficult things in the past, so just reminding them of what they've dealt with in the past and how they've had at one point resources to deal with difficult situations. And a lot of my patients tend to believe that by worrying about their cancer coming back, they're actually going to be more likely to catch the cancer early because they'll be able to detect signs and then they'll get in faster, and then this means that they'll be more likely to survive. Well, I question that belief with them, and I sort of show them an inverted U curve, and say, well, it's true that if you're not caring much about your health and you're not engaged, chances are that you're not paying enough attention to your health symptoms. But there could be a point at which you're now become so preoccupied with your health that now you've passed that point of good costs and good benefits, and now you're like going down. Your worries have become excessive and counterproductive. And I sort of negotiate with them, what would be an acceptable level of worry where you feel like, okay, I'm on top of my game here and I'm managing my health, but you're not at that point where you've become paralyzed by your worries. And there's a small study that looked at just helping patients focus on planning short-term goals and like focusing on values and making small plans. And they found that to be helpful to help people get past their fears of dying. So you can explore with your patients if they feel stuck and they report to you, I have no idea how to move forward, I feel stuck, I'm in limbo. You can explore with them what that means for them. What are some projects or parts of themselves or aspects of their lives that they feel like they've put on hold? And what can they do to feel like they have a future? So when I think of my future, I think of myself living probably till 99, and that might be the case for most of you. But for some of our patients, that dream of living till 99 is gone. But that doesn't mean that they have no future. So what does that mean, having a future in this context? And a lot of patients find it helpful to be able to sort of set small goals for the next week, the next month, the next 6 months to get past that feeling of being stuck. So to conclude, fear of cancer recurrence is a very frequent concern that will likely not get better with time. While there are tools that are available for screening of patients with possible clinical fear of cancer recurrence, they very much remain research-based, and more work is needed to bring them into the clinical setting. There's really good evidence for individual group cognitive behavioral therapy and mindfulness, and I think the evidence is growing that we'll have practice guidelines available in Canada in the very near future. And I'll conclude by telling you what I always tell my patients. I cannot get rid of your fear of cancer recurrence. However, I can help you learn to manage it better so that it doesn't have such an impact on your quality of life. All right, so here are a few resources I left you with, the Australian guidelines and some systematic reviews on tools and evidence, as well as more details about our intervention. And then here's time for some questions. So this is very much a psychology professor type of question, so I apologize. Which of the following will help a cancer patient with high fear of cancer recurrence? A, assessing their fear. B, giving them information about signs of a cancer recurrence. C, offering her additional tests just to be sure and calm down their anxiety. D, tell her everything is going to be okay. So now you have a choice with all of the above, A or B, A, B, and D. All right, looks like most of you got the right answer. I hate when I create these exam questions and my students get back to me and like, Dr. Lebel, that question, it just wasn't clear. Can we take that question off the exam, please? All right, so question number 2. Which of the following statement is true? Most of your patients experience fear of cancer recurrence. In most cases, their fear of cancer recurrence will get better with time. Most of your patients experience high, what I call clinical fear of cancer recurrence, or D, all of the above. So we're looking for true. Oh, pretty cool. And people are allowed to change their answers if they, okay. Neat. All right, very good. And, all right, now it's time for questions, and I left my email in case you wanted to ask me something else after the talk.
Does anybody have any questions for Dr. Lebel?
Can I ask a quick question?
Hi.
So everybody is scared, and I think you said there was a 10% sort of morbid fear, which really affects their quality of life. Can we pre-identify that 10% by any pre-morbid psychological state? Because we're in an era of precision medicine trying to only treat those who really need it. Can we pre-identify? Is there any simple tests we can do when we very first see the person, so we put our resources towards them and pick up the outliers later?
Sure. So there are some screening instruments available, as I said, for research purpose. So it's a bit hard to get your hand on them, but chances are that if you were to use a simple screener, and even at the first meeting that person was in that very high range, that they would remain in that high range. And that's an 11-item screener. So it would be possible for clinics who'd be interested to use that and apply a cutoff score. In terms of psychological morbidity, that's a question that comes up. Are these people with a pre-existing anxiety disorder, if that's what you're asking? Not necessarily. So there's not a lot of strong overlap between people with fear of cancer recurrence and people, let's say, that would have generalized anxiety disorder or what was called hypochondriasis in the past. So there's some overlap, but the majority of people that have high fear of cancer recurrence do not meet diagnostic criteria for another psychological disorder. Although a lot of my patients would have probably been subclinical with some sort of anxiety disorder in the past. So there's no good indication that a pre-morbid psychological condition would be your best bet. Your best bet would really be to screen them using a brief screener. Then, of course, there's a question about what you do with that data, of course, but that's a question for any time you screen for something.
Hi, my question is that do you find difference in fear of cancer recurrence in those patients who are dealing with some complication related to treatment? So suppose somebody had radiation, they're having, for gynecological cancer, abdominal pain, bloating, and they are having bowel obstructions and things like that. Do you find a subpopulation that they have more fear of cancer recurrence?
Yes, I think the more symptoms and complications people have, the more scared they can become. And I think sometimes there becomes also an impact on the relationship. So if they feel, a lot of my patients are quite anxious and they feel that, well, a bad thing has happened to me, so that means that bad things are going to happen to me, and I'm the 1% that gets these complications, so that they feel that somehow this means that they're more likely to get a cancer recurrence. So usually an experience that doesn't go smooth sailing, in my experience, but there's no good data for this, usually can lead to people experiencing more fear of cancer recurrence. But certainly the more symptoms you have, physical symptoms, the more likely you are to experience fear of cancer
I have
recurrence.
one more question. And do you find that patients who had treatment and had a recurrence, let us say within a year, and have been treated, and the chance that they are treated well and the chance that disease is going to come back is much lower, do you find they are much more feared now because they had a recurrence and it was treated?
Yeah, so people who've had a recurrence experience in general higher levels of preoccupation with that their disease will progress or worsen in general. But prior to having a recurrence, there's not much good data that shows that people with more aggressive cancer will report more fear of cancer recurrence. So just because you have like somebody with stage 1 doesn't mean that they won't experience fear of cancer recurrence. But yeah, once you've had a recurrence, chances are that these people will have a bit more preoccupation with that.
And sorry to ask one more question. As you had given some information about head and neck cancer data, and you know head and neck is very difficult to treat, and once they have radiation, they have so much trismus and things, and finding a recurrence in that situation, and as you mentioned, they are in so much post-treatment effect. Have you come across that? How can you give them reassurance that nothing is going to go bad? And,
Yeah.
you know, and then
You can't.
you are giving them this reassurance and something goes bad.
Well, that's it. So you can't give reassurance. For people who are very highly anxious, it's very hard to give them reassurance because you cannot guarantee. You can tell them everything is going to be okay, but they can come back to you and say, well, how do you know that? You don't know. You can't give them guarantees. So I think presenting the information and reassuring people that you'll be there and there are treatment available is probably what's most helpful. But yes, there are no guarantees, and acknowledging that that's difficult. It is a difficult experience to not know for sure what's going to happen.
Thank you.
Yeah.
Hi, that was great. I have two questions. One is, we have some patients who've been going through sort of like a mindfulness almost program when they're first diagnosed with advanced disease, because we know that the stress levels are higher, et cetera, and anxiety is higher. And I'm wondering if programs like that would impact on how they view or fear recurrence, because usually patients selected for these are already people who have high anxiety. So I'm wondering if the treatments themselves have longer lasting effects and whether or not they sort of need to be retreated after they've completed all the treatments for fear of recurrence.
Well, there would be good evidence that mindfulness-based programs could be helpful across the board with lots of different symptoms, depression, anxiety, and fear of cancer recurrence. So chances are, but of course it depends who decides to go into these programs. These might be people that have more fear to start with, but chances are it's a helpful strategy. Now, I think we're not yet at the stage of like a step care model. So sort of first line of treatment would be some psychoeducation, then second line of treatment might be a group coping strategy or mindfulness. For that 10% of patients that really struggle with high levels of fear of cancer recurrence, unclear how much of them would benefit from additional one-on-one services. You know, that step care model. So we don't know if it would be better to offer them one-on-one services or if, you know, a group intervention, what level of care they best need at this point.
Okay. My second question has to do with ovarian cancer patients. And we know that whether they're stage 1 or stage 3 or 4, they're high-grade serous. The chance of recurrence is 75, 80%. Now, how do you reassure a patient when they ask you, what's my chance of recurrence? How can you reassure them when you know that their chance of recurrence is 75, 80%? Because, you know, if you reassure them too well and they have a recurrence, does that come to backfire on you in the way that they trust you later?
Yes, I think so. I think it's best to be honest and to give them the information as much as they want to receive it, being respectful of not giving them information they're not ready to hear yet, but giving them accurate information. We found in our pilot study of this intervention that it worked just as well for women with ovarian cancer than it did for women with breast cancer. So despite the fact that these women with ovarian cancer had much poorer prognoses, they still got something out of the group therapy, the same way that women with much better prognosis breast cancer, because it's not, yes, you might be more likely to have a recurrence, but you don't have the recurrence right now, and it's about how you can live tolerating and managing that fear in the moment. So it seems to work well even for people with much poorer prognoses.